Assalamu alaikum, everybody. My name is Dr. Amir Abbas. I'm talking to you people from Pittsburgh, United States, and all of you know that coronavirus pandemic has created a lot of problems for everybody around the world. Today we have an expert from UK. He is an intensivist and anesthesiologist working as Doncaster and Bassett Law NHS Trust. He has done his MBBS, CPS, FCPS, FCARCI, and AFICM from UK. Without any further delay, sir, his name is Dr. Najaf, and sir, we welcome you to the show, and thanks a lot for giving us this opportunity uh, to give us an insight about how the COVID-19 pandemic is behaving in UK. So, without any delay, I would say, how are you doing, sir? First of all,
I'm fine, Alhamdulillah, in the fasting month.
yes, it's the fasting month. So, how is COVID-19 currently doing in UK? Can you give us an update on that?
Yeah, well, we feel ourselves not completely at the end of the storm. Storm has just passed. So, the last week we got a sigh of relief, and number of the patients being admitted in the hospitals are gradually decreasing. But the nationwide scientific advisory group, emergency SAG, what we can say SAG, has published on 9th of May uh, their figures and facts. And amongst those, 2-3 figures I'll share with you in context of this question. The R is the rate of the transmission of the virus, which was in the middle of April was quite high, 2.7 to 3, meaning an infected person can transmit the infection to 3 people simultaneously. Now that has been decreased to 0.5 to 0.7, according to our Prime Minister last week. But just now I was touching that, and it came up again from 0.7 to 1. So, but still it's below 1 throughout the country. So meaning one person can infect at the most simultaneously, one person. So the target was to keep that number below 1. And the other facts are that, nationwide 236,000 people were turned out positive in this epidemic, and amongst them, not half of the population is recovered, but still 136,000 are still positive. And amongst those, I would say maybe around 10% of them are still hospitalized. 13,500 is the number which has been given on 9th of May, that they are admitted. They are still in the hospital with the COVID condition. But the number is decreasing. The death toll is decreasing gradually. Today is 428. We were touching 1,000, as close to the Spain and Italy in the end of April. So yeah, to summarize that, we are just at the end of the storm. But these kind of pandemics, the resurges are always a problem. When you are already on the downside of the curve, even then you may feel some aftershocks and surges, and then completely flat. So 99.9%, we hope that it will diminish by the end of June. And that's why the travel plans and all the things like shops and restaurants, pubs and cinemas and everything will resume by the end of June or beginning of July, I'm afraid.
So that's amazing news to hear that UK is recovering. Obviously, there has been a lot of problems for the government and for the people. So can you share some of the experiences that how the UK government has been successful in controlling this spread of pandemic? As you say, that the rate of transmission that is up which we call epidemiologically, which we call as R naught, has been initially decreased and now still it's increasing. But can you just enlighten us in terms of the public health measures which were taken over there?
Yeah, actually, they were always guided by the Scientific Advisory Committee and the epidemiologist, a group of epidemiologists. And they actually, I mean, in spite of all criticism, what they had in the news, but like I would definitely praise them, because from the very start, on 3rd of March, on the 4th of March, they advised apart from the social distancing and hand hygiene and other things, they uh, they made a decision that like anybody who is having symptoms like persistent cough and the temperature more than 38.7 should keep themselves self-isolated for 7 days, and then for 14 days if they have any contacts, and their pays will be protected. So I mean, and that I think that was the first step from the government side, I think, and that was part of the 4 strategy plan: that containment, delay, and then mitigation, and then research. So these were the 4 strategic plan from the government from the start. And they wanted, actually, basically, there was a delay of 2 weeks, as the news always criticized, as the news media and members have always criticized upon them, that like I mean, contrary to the fact that like Europe was shut down 2 weeks before, and why the UK didn't shut down earlier. But I think they wanted to make the NHS, uh, I mean, the number of infections cannot be decreased, but like, they wanted not to have a quick surge and peak of the curve quickly, but they rather wanted to make the curve flatten so that the saturation of the NHS, because the NHS is, I'll tell you a background if you're in US or any other part of the world. The NHS is the only health supplier. I would say 99% of the people benefit out of them, and it's completely free of cost, and it is government organization. So they they knew this fact, and obviously they didn't want to saturate the NHS quite early. And we have seen that strategy being successful, although their target was 20,000 deaths, and now it's more than 35,000, including the care home deaths. But what I'm saying is that like the curve has been flattened by their strategy. The numbers of infections are down. The intensive care bed, I'm an intensivist, and I can give you the number of intensive care beds. Even in the peak, in the second week of April, the occupancy of the intensive care bed was 51%. And now today, as we're talking, 27% of the ICU beds were, and not only that, but they were ready for more than 3,000 beds in terms of Nightingale hospitals in London and in Harrogate and Scotland and other parts of the country as well. So they had a contingency plan of getting ready more than 3,000 ICU beds at any time they wanted. So, and in the middle of the crisis, obviously our Prime Minister, Boris Johnson, got himself COVID-19 and got admitted, and it was quite a moderate to severe disease. So, but in his absence also, the parliament members took over, and they were doing the daily briefs. And I mean, they did a marvelous thing that, like, the economic bailout package they had given to the public, that like public should not worry about their wages, and the 80% of the wages were covered. What we have seen in the US is that like 3.5 million people got unemployed. But over here, at least the people are not worrying about their bread and butter, and they are just relaxing at their home. Although there are some problems of domestic violence and all those things, which are part and parcel of any society. But the thing is, as a whole, 99% of the people were safe in terms of their wages, in terms of their health, and the other issues. And I think that was a great success. I can't hear you.
My phone was mute. I'm sorry.
Yeah, yeah.
So I think what the key takeaways from your this point is one is that you have to make a very effective social isolation plan, and second is that you have to secure this financial stability and security for the people so that they are not worried that their bills are going to be paid on time, and that's how I think, and that was might be the reason of the success, because as we see in the lesser developed part of the world like Pakistan or India, people are more worried about their wages and things like that, and that is creating a confused phenomena. We'll come back to that. So having said that, we talked about the public health measures. As you are a clinician and intensivist, so what measures were taken in the hospital to control the spread of this infection to other patients? And so there are two questions in this context. One, were the routine operations decreased, or how was they dealt with? And second is, I mean, what measures were taken from the perspective of infection control?
Yeah. That's a very important question. And actually, I was part of one of the team which managed the whole structural reorganization. So the elective operations were cancelled, full stop. They were cancelled. But the emergency operations, cancer and urgent operations, obviously they cannot be postponed. So they continue to run. And the staff redeployment was a big issue, actually, because the outpatients and other physicians took over that way, that like they start consulting from home. And although they were self-isolated for some sickness issues, but again, they were very helpful in doing the consultation from their homes. And they were also part of the team who can take some big issues with the intensivist and with the anesthetist, are like, what patients should be escalated and what patients, we should draw a line, actually. So that was another issue. The third issue, as you highlighted, the infection control. The infection control made a marvelous job. I can witness in my hospital that like they haven't they took care of both the patients and the staff. The patients, in the sense that like they evacuated the hospital wards for the COVID patients, because they obviously a huge number of patients and influx of the patients were expected. So with the help of community nurses and with the help of community practitioners, they send the patients home, obviously with the constant surveillance, with the help of the NHS 111 and the community services and the GP services. So the less urgent patients or the less disease patients can be safely managed at home. And of course with consultations and with the helps of their respective specialist consultants. Then in the second part was to redeploy the staff. Suppose an optometrist whose clinic is off and who has nothing to do. So what they did actually, I'm giving you an example. So what they did actually, they debuted that optometrist to test the face mask testing for the staff, because even the FFP3 mask which you use for as a personal protective equipment, PPE, but how can I be sure that like this mask is completely safe for me to handle the patient? So in that kind of job, like this FFP3 mask with the hood and with the spray is okay for you, any leak is there? If not, then they do the electronic testing. So that kind of job was given to the optometrist, for example. So the redeployment was from the top to the bottom, like from the top-notch consultant to the very low staff like band 4 or band 3 nurses, and the cleaners and porters, and every nook and corner of the hospital, you can see the staff was redeployed. And not only that, but the infection control also marked the areas like the yellow, black, and blue areas. So yellow areas were the infected areas or the suspected infectious areas. The black areas were kind of human traffic is possible, and in between the corridors and those areas were black, and the blue areas were for the ordinary patients who were non-COVID or whose status was cleared enough from the consultants that like they are COVID free. So and also they made sure that like the PPE are in abundance supply, and the antibiotics and other things are in abundance. The medicine supply should not be short, because the problem was that like the borders were closed from the EU, and the UK relies solely on the EU for their medicines and supplies, or China. So the air borders and the land borders were all closed. But in spite of that, apart from few minor bumps, I can assure you that we didn't feel any shortages or any problems in terms of PPEs, medicines, staff. So everybody was helpful actually, and the morale was so high generally that like it's a national disaster. We have to deal with it, and criticism is and myths and conspiracies, people took it away on one side and put it in the rubbish bin, and they had a positive state of mind and a morale that like we would all have to help. And the public had given marvelous support as well to the NHS, because they knew that it's a backbone of our health system. So they came forward, and it was amazing. I was in the middle of the night doing my duty, and I found that a tray of croissant and cold drinks were brought to the hospital by an ordinary person, by a baker, for example. And and the ladies who are expert in sewing, they were sewing the gowns at remote villages and were transporting by their own expenses to the hospitals. So these kind of examples show that uh, although whatever their religion and whatever their cultural background is, but they rose with a nation sense of nation rather than a crowd actually.
That's quite motivational, actually. And I'm glad you talked about PPE. And there's a very serious problem in Pakistan or other developing countries in the context of PPEs. So I would just ask you that, just for the sake of convincing the administration that, though you mentioned it, but how, so I will ask you again two questions in this context. Can you give us an overview of what is a PPE in this context, and how important it is in management of this disaster in this situation? And as you said that it's very important for the supply to be abundance, and if there is a limitation of the supply, what do you suggest then?
Yeah, actually, the more the better, because we know that and as an anesthetist and as an intensivist, who knows more than the problems which one can face, because we are the people who always intubate and put the patients on ventilator. So the aerosol generating procedures we directly deal with. The physician, I mean, might be at the end of the bed or the outside the room giving some consultation and advices, but we actually have to accustom to the patient with the nurses. So what I'm saying is that the PPE is for our own protection, personal protective equipment, and it includes from the face mask, like the specialized face mask which have the special filter, FFP3 filter, or N95 in the common terminology, with the gowns, with the visor, with the goggles over your glasses, um, overlying hood to cover your hairs, and shoe covers, or a complete dress, like, the white or blue or whatever color, the complete dress, which can protect you. And the donning and doffing is very important while you are putting on and while you are putting off those clothes and those equipments. So you have to properly do it, otherwise you will self-contaminate yourself while you are doffing it off. So it's whole sort of training, and again, infection control played a marvelous role with the guidance of the Public Health England. They advertised, they started video programs, demonstrations, and it was completely a learning curve for everybody, including myself, because it was once in my lifetime. I've never dealt with the Ebola, I've never dealt with the SARS virus. H1N1 in 2009 we dealt with a few cases, but not a whole lot pandemic. So what I'm saying is it's it's a learning curve for everybody. One has to learn every day in science, actually, what they say. So the PPE was an issue, and as I said, like the public had given a marvelous support, like the transport workers, the key workers, lorry drivers who used to carry the PPE. I mean, they were all very supportive, and and on one occasion, I can witness that, like, the army came forward as well for 2 weeks, and they started, because when they saw the need of the PPEs, especially in the London hospitals, which affected a lot. London is is the most affected city as New York in this COVID season. So the stockpiles from the business areas, they supplied to the hospitals directly for the staff and for the patients, and that was marvelous, actually.
Okay, so we move a bit further in this discussion. And so what is your input? Can you give us an overview of the tests which is conducted for COVID-19? What is your expert opinion in this context?
And regarding the deaths, yeah?
Tests, sorry, the diagnostic tests for COVID.
Diagnostic tests, okay. Sorry, I couldn't get it. So the tests, we all know that, like, one test is there at the minute, the antigen test. The antibody test is still experimental, in the experimental phase, and few experiments have been done, and few countries, and lately I think Oxford and Cambridge have developed a kind of antibody testing. But the main diagnostic test for COVID-19 is antigen test, but the specimen can be different, and a specimen from the nose, nasal swab, throat swab, or when we put the tube in, and the bronchoalveolar lavage swab, or the sputum swab, or the fiber optic bronchoscopic brushing swab. So stool or serum, or so all kinds of secretions and all kinds of body fluids can be tested, but the sensitivity is different, obviously. So the nasal swab, for example, is only 63% positive, true positive, uh, and the throat swab is even lesser, at 32%. So what I'm saying is, why I got this idea to, and I immediately responded to your call, because I saw a video clip on the social media from Pakistan. Like, one guy was showing the Aga Khan University report of the swab test, and that was negative, and he was saying in that clip that, like, my wife was, in spite of the negative test, was admitted to the hospital, and they put her on ventilator, and sadly she died. So what he was accusing, basically, that, like, they are filling the numbers instructed from somebody, and they're getting money out of it, and whatnot. These are all conspiracy theories, but the thing is, they're saying that, like, in spite of the negative test, why you are putting patient on the ventilator. So my whole point was to emphasize that like, it's not, there are many factors, and nasal swab and throat swab, if you do it properly, even properly by a proper technique, because the technique also matters a lot. because my own test was done by a faulty technique because my household was affected. So I had a test as well. So what they did actually from my car, uh, she was in PPE herself, and she had given me the stick to my hand. And when I hold it, so when I hold it and when I approached to my throat, I gagged. So was it a proper sample or not? I'm not sure. The second thing, when I put it into my nostrils, how far it should go down, I'm not sure. Some people do very deep. Some people say it's enough to have some just touch of it. So what my point is that like the technique matters a lot. The reagents which we are getting from substandard reagents, like any country who makes it, like Taiwan or China or anywhere from anywhere you can get it. So we are not sure about the reagents. We are not sure. And again, and if it is done properly, even then the sensitivity or the false, the true positivity is only 63% from the nose and 32% from the throat. So you can imagine you can have the negative results. And in my own setting in intensive care, I can witness 3 patients who were swab negative. But when we put the tube in and when we send the tracheal aspirate, they were positive, and from the day one, we put them in, we kept them in the side room, and then when they were positive, so we started treatment on that line, obviously, and they were already they had been started already, that treatment, the supportive treatment. But what I'm saying is that, like, the false negativity is so much in COVID virus that, like, you cannot rely on just throat and nasal swab. You need a very deep specimen.
Yes, I think, and this is to take your discussion further. This phenomenon of being false negative, it's not related for the general audience and general public who are non doctors and do not have any medical training. I have to emphasize this, that this is a phenomenon which is attached to any test. Even if you doing your hepatitis screening tests or you are doing any test, there is a rate of sensitivity, specificity, especially in some of the false positive rate will be associated to any test. And I'm glad that you mentioned it. There has been an incident in Peshawar as well, where a patient was COVID-19. A young boy later died sadly because of, and he was in ICU and he was labeled as COVID-19. And the tragic incidence was there was a lot of psychological burden for the family because what happened that the hospital labeled that person as COVID-19 positive, and they repeated the test, and the test came out to be negative. Uh, the burial was done with the preventive measures being taken. The government supervised it, so they didn't show the family the face of the patient, which resulted in a lot of psychological distress for the patient. So I think this point is very critical, that one thing that it can be false negative, and that is not going to add to the conspiracy theory that this is not a reality. And I think conspiracy theories are becoming very important problem in this context. So going forward, uh, what can you give us some idea about the management of COVID-19 patients? What guidelines do you follow?
Yeah, actually, this disease was new. Uh, although we already had such kind of infection as in H1N1 in 2009 and 10, but like that was on a very small scale, and that was restricted to only few countries, few endemic areas. So then it was not labeled as pandemic. That was purely an epidemic issue. But this time around, when this is started, when this by the end of February, and in the first week of January in China, actually, so the guidelines and protocols started erupting in all leading medical journals, like Lancet, like BMJ, like BJ, you name it and you get it. So many researches have been performed already. So the guidelines were formulated in our own local hospital by the public health guidelines. in light of all these studies. Um, but the thing is, the main criteria of management, when it comes to management, I think I have never seen in my whole life such a dramatic, I mean, the policy was implemented and it was executed actually. Policy was made and implemented, and it was very well executed in my own hospital, what I can witness. They're like, when I said yellow areas, when you where you admitted where you admit the patients with symptomatic coronavirus, you start immediately management as you have already categorized as the policy dictates. So for example, asymptomatic patients, the government advice was that, like, if you're even if you are asymptomatic, your household is positive, you go and get your test done, and when the test is positive, you stay for 7 days in the hospital, at your home, self-isolated. And if your household contact is infected and you are not, then you have to stay at home for 14 days. God forbid, within 7 days, if you start having symptoms like persistent cough, sore throat, myalgias, like fever more than 37.8, so and anosmia, loss of taste, loss of smell. So if these symptoms appear, you go to the emergency. You first talk to the 111 NHS 111, and then you go to emergency. And in emergency, they will be labeled as mild, moderate, or severe. They will, in light of the test, obviously. And if you're positive, and if you have developed symptoms, then they will label you as mild, moderate, severe. In mild symptoms, they will give you some oxygen by nasal cannula or the face mask oxygen, and then they will keep you in isolated room. And all sorts of supportive treatment will be given to you. And the nurses will keep an eye on your oxygen saturation and your vitals, and they make a scoring system, and on that basis, they go from there. So if there is scoring system over few hours or days, if he or she starts deteriorating, then they will then they will label him as a moderate disease patient, where he's not maintaining his oxygen in spite of oxygen given to him. So then a positive pressure mask will be given to him, which we call as CPAP mask, and that has a limit as well. That, like, you're not supposed to give more than 60% FiO2, like 60% fractional inspiration of oxygen. You should not give, otherwise the lung fibrosis will happen. So and the CPAP pressure of 10, for example. So that was the cutoff limit for that. And if one gets more than that, then the intensive care outreach would be called. An outreach nurse would go and immediately see this patient with the proper PPE. And then if he thinks that, like, patient is deteriorating and he should be in the intensive care, then they give us a call. We visit to the patients. We see in the light of his background, if he's 65 years of age, and if he's frail, if he has a underlying medical conditions, and if his quality of life is not very great, like if he's not independent person, then probably we would say that, like, this is the ceiling of the care, and we would not admit him, because we wanted to save that bed in the intensive care for a more young person with no underlying problems. Although a lot of criticism you can do on that matter, but what I'm saying is, emphasis was to follow the guidelines and protocols which were made for the masses actually. So and then that guideline was supported by not only one-man decision by an intensivist, but a group of members of the medical consultants who were looking after that patient since years and years. So they can, when they're all in consensus that, like, yes, this patient should be going to the intensive care and give him a chance, then probably he would come to the ITU. And intensive care, obviously, if he's not maintaining oxygen, then probably will intubate him, will put him on ventilator. Sometimes, if the ventilation is difficult, we would have to make them prone, because as you're aware, that our posterior part of the lungs, or the back of the lungs, they have big capacity than the anterior lungs. So if the anterior lungs gone is stiff, then you lie them on your tummy, on their tummy, and then patient breathes through the ventilator while they're prone. A lot of nursing is needed in that, like every 4 hours posture changes, like the head position changes, and every 8 to 16 hours you have to turn them back supine to give them feeding properly, to give them nutrition, and do other measures in intensive care. So that was a very remarkable experience. The numbers of the patient was very high. The numbers of his staff, the nurses, uh, the doctors, the roles were amazing actually. But you see, at this point, I would say the nurses did a great job, because for us, for doctors, we just go in our PPE, do around, give instructions and come back. But for the nurses, they have to hang around with the patients all the time, 8 hours, 12 hours shift. And believe you me, I have seen myself the scratches on their faces, the rashes on their faces, and sometimes they erupted out. They used to break out in tears.
So that deserves appreciation. I mean, like all the doctors and all the staff, but especially the nurses. Yes, we know that nurses have a very important role in all the medical care, and especially in this pandemic. And we have been seeing a number of pictures in the social media as well, where the scratches are, from them. And yes, I think that deserves a lot of appreciation. And there's no words who can express and appreciate that. So there have been a lot of discussion in the medical community related to hydroxychloroquine. That has gone down. I'm not seeing a lot of discussion right now. What is your take on that? And whether hydroxychloroquine or any other treatment, uh, has there been, so what is the update on this line of research?
Actually, as we said, we are talking now the fourth part of the strategy, that is the research. Now, supportive treatment is the mainstay in these, was the mainstay in these patients. A, because we don't know the disease. B, the randomized controlled trials were not there. Now, what we rely upon is the cohort studies from China or from South Korea, and from the countries who had already dealt with it. Like a lot of papers were coming from Italy and Spain lately. So what I'm saying is that, like, yes, we made the public health guidelines dictated us that, like, we run a trial, recovery trial, and that was a nationwide trial. We recruited 25 patients into that as well, and that had 5 arms on that. The first arm was standard, whatever you're doing, you continue to do that. The second arm was giving hydroxychloroquine, as you mentioned, because hydroxychloroquine is an anti-malarial drug. We know this drug since centuries, but it has added benefit of giving some anti-inflammatory potentials, like the IL-1, IL-6, and TNF-alpha. It hits on that. The cytokine syndromes, we medical community might know it, that, like, it's a cytokine storm was very common in this COVID-19, and such a massive inflammation. So it acts as an anti-inflammatory agent. And some people have promoted black seeds as well in that regard as well, like the what we call in our Urdu as kalonji seeds. So that contains thymoquinine, is a kind of a natural substance of chloroquine. But anyways, that hydroxychloroquine was one arm. The third arm was leptovinir and ripovinir, which are famous anti-HIV drugs. The fourth arm was methylprednisolone, And the fifth arm was tocilizumab, which was used in Ebola and MERS. So the trial is still running, and the randomization was done by the computer. Apart from that, if somebody wants to use any drug on a compassionate basis, any clinician, they can use it. But the supply was an issue here in this part of the world, where we are governed by strict pharmacological surveillance. Like pharmacy guys, comes and do rounds every day, and we cannot deviate from their guidelines. But anyways, we can use it. We can use our powers, and we can use our on a compassionate basis. And we have used like methylprednisolone, because methylprednisolone obviously is being used in ARDS, which, like, the ARDS happens in COVID as well all the time. So that's why we were using methylprednisolone as on a compassionate basis. But I have not used the hydroxychloroquine myself in any patient. And leptovenir, ribavirin, and toci, and azithromycin, these were, we left the decision on the microbiologist and infection control and the pharmacist, and they were all very hesitant to use it in the first place. But like, our number of the patients were not that high, so I think we might get some idea from our London colleagues and nearby colleagues that, like, have they used it, the hydroxychloroquine, and what are their results. But like, I've used on a compassionate basis on 2 patients methylprednisolone, and even though their randomization was not there for that, and that both of these patients were randomized to the standard care. But yeah, you can use it. You can use hydroxychloroquine with azithromycin, and people have used it on a compassionate basis in many parts of the world, including America. I have seen one or 2 case reports as well.
Right. So the conclusion is that research is still going on in this area, and it's an active area of research, and we still do not know a lot of things. So anything cannot be said conclusively in terms of the treatment of this condition. So with all this background and all this elaborate discussion, we have done a very comprehensive overview of the strategy at the level of the public health, at the level of hospitals, from the perspective of the PPAs, how the hospitals are managed from the perspective of the hospital administration. Now, the situation in Pakistan is very unique, and there are unique problems over there. So with all this thing, and knowing the situations in Pakistan, so we go stepwise. So what message will you like to convey to the clinicians in Pakistan?
Well, they have to come forward. That's the main message. They have to be a leader. When it comes to health, I mean, we have left the decisions on the policymakers in their chambers, who doesn't know anything about health. So the health ministers and health secretaries, I mean, these people have political affiliations, and they make the decisions on influences, and those influences may be anything. So what I would say, that like, the clinicians in these tough times, clinicians have to come forward. Up to 2-3 days back, I was hearing the news that in Karachi, the biggest city in Pakistan, the whole coronavirus cohort were left on the mercy of 2 charitable hospitals. One was SIUT, the other was Indus Hospital. Come on, now this is shame on us, that like, no government hospital had come forward and say that, like, we will admit maybe around 500 patients of coronavirus patients here. We have 40 bedded or 50 bedded isolation unit. We have 50 ventilators ready. I mean, nothing. I haven't heard any news, any of such news from the government sector. So, I mean, this is the time when we would have to react and fight, because I know that like over there, the fight is double. One is the fight against coronavirus, and the other fight is fight against ignorance. And people even don't believe that like coronavirus exists. I've heard these news as well. That like people think that like this is just whole a hoax or a fake thing. Come on, this is not a hoax. 300,000 people have died in the world, and more than 4 millions have been affected. So in many parts of the world, people have died. You can comment upon the origin of the virus. That like origin can be manipulative. Maybe it is synthetic or maybe it's natural. We don't know. But now it is there. Now it has caused the damage. We have to fight the damage rather than focusing on the initiation, how the virus has started. And actually, they have to come forward and be leaders. And according to their circumstances, they have to draw guidelines and protocols that, like, look, these are the guidelines. You have to stay at home for this period of time. And then, if you are affected, come forward, and your emergency department will welcome you. And then the outreach service and the intensive care will help you. I mean, and it's not the rocket science. I mean, the studies are there. You can take the examples of any nation, any nearby nation, and take it from there. I think I know it's a hard time. We are running the economic problems as well. Like I'm seeing daily the pictures of poor people begging around, and we have a lot of problems to that end. But life comes first, I think. And if you're alive, you can do anything you want. But like the precious lives should not be left on the mercy of your system, I think.
Yes, I agree, and I think I have also to mention that there is not a day passes when I have this message which comes to my WhatsApp that this is a conspiracy, this has done X, Y, in an X, Y, Z. And the sad part about that is it's not from the uneducated, it's from extremely educated people where this, I would say, extremely illogical messages are being forwarded. And there are
Exactly.
times where I have to tell to these people, okay, I'm not only a doctor, I'm an epidemiologist, and I know how these things function. So, okay, right now you need to listen to me because uh, this is very important. So that controversy theories are illogical, and they're sad because on one hand thousand of people are getting died, and on the other hand there are people who are chanting again and again and again and again that this is not serious and this is a conspiracy theory. Anyways,
That's a
so
shame.
having said that you have this message for the clinicians. What is your message for the hospital administration? Because again, that is also very important challenge in Pakistan. You know, the conditions of hospitals in Pakistan in routine, they're not very good. So having said that, yesterday I had an interview with a colleague of ours who she was from UAE, and what she suggested was in Pakistan, what they should do for each and every city, they should dedicate one major hospital for COVID patients and like transfer.
Exactly.
And what do you suggest for the hospital administration in this context?
I know many people, many dedicated people around. It's not, there is always light at the end of the tunnel. We, I mean, I can witness many people. My background is from Karachi. I know many clinicians that like they can do major decisions in when policy matters come. But I don't know why they have confined themselves to uh, any pigeonhole. I don't know. They should come forward, and because this is a high time. If you are not doing anything, because like the SIUT has done a marvelous job. Yesterday, I was talking to one of the senior clinician there, and he said they have 40-bedded ICU unit. And not only that, but also the negative pressure rooms, which is not available so far in UK everywhere. So what I'm saying is, if you have a will, you can do that. So 40 bedded isolation units, 15 ventilators in their intensive care, a full time screening clinic for the coronavirus patient. And same is true, I think, in Indus Hospital. So I think, and Dr. Bari again is a leading figure there. So if the people can come from the charitable hospitals, if they can come forward, why can't the people from the government hospitals? Like I know that Said Qureshi is a big name in the civil hospital Karachi. He should come forward. He's an MS. He's a very philanthropist person. He's a very laureate person as well. He's a surgeon himself. He can come. He should come forward and take the lead and gather few clinicians with him and make a policy. Not necessarily that like policy should be dictated by the health department. You can make the policy for your own hospital, because you know the hospital more than anybody else. So I mean, you can devise whatever you want. But again, I said, when there is a will, there's a way. Where that's the problem. That is lacking in us Muslims, unfortunately.
That was from the perspective of the hospital administration. And finally, I think we are running out of time as well. But in terms of public health, the overall policy for the federal and provincial government in Pakistan has been a policy of confusion. I will say it like that, because as we have been hearing in the news, I mean, somebody will say that you need a lockdown, somebody will say you not need a lockdown, and there are many stakeholders. Each one of them have their own opinion. So, what will you say to the government of Pakistan in this context?
I think in poor countries like us, like Pakistan, I would say lockdown is absolutely necessary. That's the poor man's central line of life. Actually, what you would do if the invisible enemy is there everywhere, you should have to lock down yourself into your homes. That's what would you do logically, because we don't have any health resources, we don't have any plenty of money to spend on the health sector. So the least we can do is a strict lockdown, as what the UAE done, as what the Saudi Arabia has done. They are affluent countries. I can imagine they can bear the load, but our constraint is financial as well. But this is high time that like people like us who are in affluent nations who are working, they should help our own people in Pakistan back home, and help them while they're in tough time. And I think people are very generous in Pakistan themselves. We have witnessed many catastrophes, like 2005 earthquake is a perfect example, and people from all over Pakistan helped more than anywhere in the world. So, and we are a generous nation. So I think in this lockdown period should be strictly executed, first of all. And the second thing, we should all help them as a nation, actually. There is no other way. And as I said, life is the most important thing than anything else. I mean, yeah, 2 3 days back there were some doubts about the processions and about some religious gatherings. But again, religion is there to help human being. It's not to tease you. Now, what we have done, like 8,000 people yesterday in the procession being exposed to the open environment. God help them. I can only pray for them. But what I'm saying is that that's not the right decision. People should confine themselves to a home and recite Noha and Mercia on the web, Majlis on the web, and God knows our will. When Makkah is closed, when Medina is closed, when Najaf is closed, I mean, what else you want? And our big Muraja Sistani has given the fatwa. They're like, if from me somebody's got infected, I should have to pay the monetary compensation. So that fatwa is very clear. I mean, I mean, I don't know why the confusion is there amongst our religious scholar, at least.
This is a very sad reality. I mean, this is extremely, again, I have been arguing on this point with not very illiterate people, but with extremely educated people. And unfortunately, I failed to convince most of them. And I don't know, I mean, yeah, I agree from where the confusion is coming when there is a clear fatwa, when the all of our religious centers are closed, when Masjid al-Haram is closed, when all of the, I mean, Roza Imam Ali al-Islam is closed, and when there is a clear fatwa from Ayatollah Sistani, then there shouldn't be any confusion. But I mean, we are a strange nation, so I will leave it with that. I think at the end of it, I think I'm done with my questions. Do you want to say anything before we close our discussion?
Just one little thing which came just now in my mind, and like, sense of responsibility is the only thing which is needed. Once Maula Ali alayhi salam was asked that, like, what is the worth of a human being? And he said, his sense of responsibility. Whatever the sense of responsibility I have, that is my worth. If I have this much, my worth is this. If I have this much, the sense of responsibility, my worth is that. So, in a nutshell, we should always search our own conscience and say, what is my sense of responsibility? And I think if everybody feels like that way, world will become heaven.
Dr. Najaf, you have very concisely and very effectively summarized in your last statement that everybody needs to be responsible. I will conclude it and this discussion on the same note as well. As an individual, I have to be responsible. I have to be responsible for myself, for my family. Then if I'm a clinician, I have to be responsible for my unit. If I'm a hospital administrator, I have to be responsible for the hospital administration. And I have to emphasize that a lot of information like this or from other sources is available on internet. Now the information flow is very frequent. If you want, you can have access to that. Take the information from the best available resources in the world, apply it to your unit, your hospital, and that at the level of the government. I think government needs, though there are problems, challenges in Pakistan as well, but at the same time, on one hand, government cannot say that it's not my responsibility. It is the responsibility of the government to provide
Exactly.
healthcare to the people, and at the same time, in parallel, with the lockdown being recommended by the health professional, it's also the responsibility of the government to provide food and the needed necessities to the poor as well, whether you do it by mobilizing your funds, whether you do by limiting your luxuries, or whether you do it by mobilizing and organizing the charities around the world.
Exactly.
Whatever you do, like, you have to do that. With that, I will conclude this discussion. Thanks a lot, Dr. Najaf, for giving us time for this session. Remember me in your prayers, and remember Dr. Najaf in his prayers, in your prayers as well, for giving us time for this very comprehensive and useful discussion. Thanks a lot for the time being. Allah Hafiz.
Thank you, Allah.